Chris, can you hear me? Can you hear me, Chris?
Yes, I can hear you.
Oh, can everybody hear her?
Yes.
Yes?
Yes?
Yes.
Okay. Okay, I think we're good to go here. I'm just gonna, hold on a second. Yes, no? Okay,
Well, we're good here.
I think we're good to go here.
Okay. And they could just turn off when they're done, right?
Say it again.
I said they'll just turn off when they're done? Or do you-
You can just sign off. I'm gonna make you host and you can sign off when you're
Okay, okay.
done. Hold on a second. Okay, your host.
Okay.
Can you shut? There you go. Okay, you got it.
Okay, we're good?
Can everybody respond? Can you hear the students, Chris? Somebody ask a question.
All right. Hello. Hey. Okay, you can hear me.
Yeah, I can hear. Okay, thank you. All right, we ready to go?
We're good to go.
All right, thank you, Professor Maley. I'll talk to you later, okay? Did he leave?
I'm still here, but I will be leaving in a moment.
Okay. So I'll talk to you after this is over.
Okay, okay.
All right. So we talked about the rule of nines and we ended up on pressure, wound classification for pressure sores, correct? I believe. What is that noise? Oh, geez. Okay. All right. So what are the cardinal signs of an inflammation? We said they were swelling, pain, redness, warmth, loss of function, right? Those are the cardinal signs of inflammation. It's an important thing to know. So when we talk about pressure ulcers, classification of pressure ulcers is a little bit different than the wound classification, but we need to assess what a wound is. And according to the Pressure Ulcer Advisory Panel, the National Pressure Association, they changed the name from pressure sore to pressure injury. It used to be called pressure ulcers. It's no longer called pressure ulcers. It's called, it's either you'll still see that terminology out there, pressure ulcers, but you may also see the terminology pressure injury. Okay, so what causes a pressure sore? Something that's, or pressure injury, something that's unrelieved. It's unrelieved pressure to the epidermis, the dermis, all the structures underlying capillaries also very involved, and it usually happens between the bone and supporting surfaces. So if you see a pressure sore and you see an open pressure sore, it's indicative of something much greater than what it looks like, because pressure sores usually occur from the inside out. So the superficial dermis can tolerate ischemia or a loss of blood to that area for about 2 to 8 hours. But the deep muscles can only tolerate those pressures for 2 hours or less. Therefore, as I said, if you're seeing some pinkness or you're seeing some non-blanchable erythema, or if you're seeing something of the in this, on the skin itself, then it's indicative of something that's deeper. So there's risk factors, and we talked about what a pressure sore was. We said that there's capillary pressure that's underneath, and if the pressure is too great for to exceed that normal capillary filling pressure, then you'll get some redness. So friction or shear forces to the superficial skin. How do we prevent these? Because that's number one. What we want to do is prevent them. So you can prevent them through changing the patient's position, making sure that the person has proper nutrition. So parenteral nutrition sometimes is required, where they have an IV and they provide nutrition through some kind of a cannula, which we'll talk about. But also that the person is eating well, and that they may need what is this, Ensure, or any of these products that have a lot of nutrients in them. Okay, so we talked last semester about the fact that we want to make sure we relieve the pressure over these bony prominences, and that's one of the things you'll be talking about in lab today, especially when you're stump wrapping and different things like that. If you're wrapping a bandage or wrapping something, you want to prevent any wrinkles because you don't want to introduce any pressure over those areas. So this is a trochanteric pressure sore, and this is an ischial pressure sore. So they can become really awful over time, and you could see that if it goes deep enough, you could see a bone. So these things should not be taken lightly, because one day you're seeing that there's pink and there's non-blatchable, and then if you're not treating that patient and that patient is lying on that sore, it can start to open up and then eventually start to get necrosis and tissue death. All right, so stage one pressure sore is the skin is still intact. There's redness, erythema. You have an increased skin temperature, but the skin does not blanch, meaning that if you put your finger in it, in the redness, it does not turn white. It doesn't flush. It doesn't flush the blood out of the area because the pressure that's applied, there's no blood. The blood will be pooling secondary to capillary damage, so it won't blanch. Stage two is a partial thickness tissue loss, which involves the epidermis and part of the dermis, where the skin is pink, moist, free of necrosis. That's known as a partial thickness, and you may often see a blister or an open serum-filled blister. You could also have a shallow open ulcer, and then the wound that is pink without slough. Okay, remember what slough was from the other day? That yellowish color. So stage three is a full thickness tissue loss. It can be subcutaneous, can be necrotic. You can see some infection. It's a full thickness. You see some exudate, and the exudate can be any color, but the bone, tendon, and the muscle are not exposed. You can see tunneling or something known as undermining. So it's a crater-like in appearance. And tunneling means that if you put a cotton swab in, and generally what we do is we have these long cotton swabs, and you place it inside the wound, and it not only goes down in a vertical direction, but the sore actually forms a tunnel. So you could put the swab in a horizontal direction and it keeps going. So that's indicative of a tunneling or undermining. That's a large wound. Stage four, deep fascia, joint tissue, bone necrosis, definitely tunneling. And if something is unstageable, it could be a full thickness tissue loss. The base of the ulcer is covered with slough. You cannot stage it. So if you can't stage a wound, you don't stage it. Okay. The other thing about these wounds is that once it's a stage three and it starts to heal, we don't call it a stage one. We call it a stage three healing ulcer. Okay. All right. So here are, I don't know why we can't see this better, but erythema, intact skin, partial thickness, skin loss. The ulcer involves the epidermis, dermis, the subcutaneous layer, looks like a crater. And then I guess I could pull these over. Let me see something. Oh, Let me just see if I could pull this over so that you could see that. Okay. It's not much help, but subcutaneous ulcer extends down to the fascia and appears like a crater. Here you're seeing bone. So that's a stage 4, full thickness, skin loss, excessive destruction, damage to the bone, joint capsule, and here are the areas of the skin that are involved. Okay, so stage 1, you see it pink or you see it red, but it's non-blanchable. Okay. Stage 2, you may see some blisters. You see the epidermis is involved and part of the dermis. And then stage 3, it involves subcutaneous tissue, and then stage 4, full thickness destruction. So if you ever see a question on the state board where it talks to you about an intact blister, you would call it a stage 2. Okay, if fascia is involved in subcutaneous, stage 3, and bone, joint, and tendon capsules, joint capsules, are stage 4. So full thickness loss where ulcer is covered by slough and or eschar is known as an unstageable wound. There are sometimes, as I showed you a picture yesterday, there was an eschar on the heel. So if eschar is on the heel, it serves as the body's natural cover and should not be removed so that you could stage it only if the eschar is dry, intact, and does not have erythema. Okay, otherwise it needs to be removed. But generally, if you see the eschar is dry, intact, without erythema, you could leave it alone. All right. So number 1, how do we talked about yesterday or Monday also using the Braden scale to assess the risk of pressure ulcers. But one of the things that we want to do is we want to make sure we perform pressure relief. So how we do that is through turning the patient, through positioning the patient, and to give patients, wheelchair activities such as a wheelchair push-ups, relieving the butt, or if they can't push up on their arms, they can move from side to side. Turning the patient, proper nutrition, a lot of water, avoiding shear forces, keep that person active, do debridement, whether it's mechanical debridement or non-mechanical debridement, which we'll talk about. Appropriate wound care, attention to incontinence. Why attention to incontinence? What do we have to worry about with incontinence? Anybody? With incontinence, we have to worry about
infection.
Infection and maceration. Remember maceration the other day when you get a breakdown secondary to, you could have dehiscence, the wound could actually open up due to maceration. So we want to make sure that that person is not incontinent. If they are, they need to have a catheter or something, or they need to have care taken that the area stays clean and certainly clean to prevent infection, and also dry to prevent maceration. You can rinse the ulcer with saline, especially if you want to clean it out or you want it to help take off a bandage. You could make it wet by putting saline on it. Assess the dressing changes, provide patient with appropriate education, and number 1 for pressure ulcer management is prevention. All right. PVD, peripheral vascular disease, is a general term that describes disruption of both the arteries and the veins, so arterial and venous flow to the extremities. When we talk about arterial wounds, and by the way, the most common cause of leg ulcers that you'll see are venous insufficiency. So they're the most common. Factors interfering with arterial insufficiency. If somebody has atherosclerosis, we talked about atherosclerosis and we said that was the formation of lipids or plaque formation in the arteries. Arterial sclerosis obliterans, that's a peripheral manifestation of atherosclerosis. So risk factors for that will include diabetes mellitus, which we talked about the other day, hypertension, smoking, and hyperlipidemia. Okay. It's usually characterized, any kind of an arteriosclerosis, rest pain, trophic changes, any kind of an arterial problem, and we will go into detail on this. Intermittent claudication. Intermittent claudication means calf pain, pain, and it's intermittent. So as it becomes more steady, or it lingers on and becomes longer, it's indicative of a greater arterial problem. So somebody with intermittent claudication may be walking in the mall and they say, well, I get to about 5 minutes and then I have to sit down because I have calf pain. So that's indicative of an arterial problem, which is different from a spinal stenosis. If somebody has a spinal stenosis, they see somebody with an arterial problem will say, I feel better after I have this pain in my legs. I feel better when I sit, because they're no longer requiring the legs to do as much work. But a person that has spinal stenosis, when they sit, they flex forward and they give the spinal canal some more room, therefore taking pressure off of the nerves. So a person that has arterial problems will has something known as intermittent claudication. So once they walk and they have pain, they sit down, it feels better. Thromboangiitis, now obliterans is known as Burger's disease, and that's an inflammation which causes arterial occlusion, especially in the fingers and the toes, due to ischemia, and it happens with smokers. So it's due to a decreased amount of oxygen. And finally, Raynaud's disease. Raynaud's disease, a person has pallor, cyanosis of the fingers. You've all seen Professor D'Onofrio's fingers. It's triggered by cold. It's also triggered by emotions. The etiology or the cause is unknown. And it's a vasomotor disease of the small arterioles and arteries of the hands and the feet. And this is an important one to know, especially if you're working with somebody who is, who you're going to apply cold or ice. So if somebody had an ankle sprain, let's say, and they needed ice to relieve the swelling, that's not an appropriate thing to use for them because it'll make this problem worse. Okay, so arterial ulcers are associated with arterial insufficiency. Venous ulcers are associated with venous insufficiency. So here's an arterial ulcer. It's most frequently located on the lateral malleolus, not the medial. The medial malleolus is the venous ulcer. It's on the dorsum of the feet. It's also on the toes. So you could have trophic changes. You could have dry skin, shiny dry skin. Nails are thickening. You could see absence of hair growth. This patient has wounds that are painful. Why? Because of the ischemia and lack of oxygen. They are, in appearance, they are dry with a little to no exudate. And intermittent claudication. Intermittent claudication is pain or cramping with walking. So if the intermittent claudication, if the person is walking, has cramping, sits down and still has cramping, is that indicative of a worsening of arterial problem or a better arterial problem? Worse, right? I mean, it should get better when you sit down. It should get better when you sit down. These people have decreased pulses. Their leg is white when you elevate it and red when it's hanging down. These people do not have, one of the things you don't want to do is you don't want to do wrapping. What's the word I'm looking for? Compression wraps. Compression wraps are not done with arterial ulcers. Okay, you don't want that compression wraps. The limb is cool to touch, and there are some tests you could do. One of those tests are when it says decreased pulses, pallor on elevation. One of those tests is known as a Ruber, R-U-B-O-R, redness, Ruber dependency test. And what it looks for is if the patient is supine, and you look at the bottom of the feet, both feet. You elevate the limbs slightly, like 45 to 60 degrees. You elevate the legs, and for about a minute. And what should happen is you should get a pinkness. If you get a rapid loss of color, that's abnormal. When you bring it down to a supine position again, it's normal for the flushing of the blood to come back into the feet, so the feet look pink. It's abnormal if the feet feet stay white for 30 seconds or longer, or get to be, and then after that time, flush a bright red color. Okay, so that's known as the Ruber dependency test. There's also another test that you could do for these patients, which is ankle brachial index. Ankle brachial index looks at the blood pressure, systolic blood pressure of the lower extremity and upper extremity. You put a cuff on the upper extremity and a cuff on the lower extremity, you take it at rest. Then you ask the person to walk maybe on a treadmill, and after you've asked them to walk on a treadmill and you look at the amount of blood flow to the distal extremity, if the ankle blood pressure is the same, or even if it's a little greater, it's normal. If the blood pressure is lower in the ankle before or after exercise, it's peripheral arterial disease. Okay, so these numbers change in different books. Don't memorize these numbers, but know that if it's less than 0.50, it's severe. And remember, I said you take the lower extremity. Let's say the systolic of the lower extremity is 90. And the systolic of the upper extremity is 120. Divide those two and what do you get? Anybody?
0.75.
0.75, right. So would that be normal?
No, that would be mild.
Right, because it would indicate that there's not a lot of blood flow to the lower extremity, right? That's not normal. So you have arterial insufficiency. Okay, so you do an ankle brachial index or you do a Ruber dependency test. So those two things are done for arterial problems. You could also do an arterial Doppler, okay, but you can't do it. It would be done in the hospital, or it would be done in a facility, okay, some kind of a ultrasound facility where they could do a Doppler and they could look at the blood flow of the vessels. You could do a venous Doppler or an arterial Doppler. But these are just tests that are done to see if somebody does have an arterial ulcer. Okay, venous ulcer. Remember, I said they're the most common cause of leg ulcers due to chronic insufficiency, chronic venous insufficiency. Okay, so they persist over a long period of time, and it's the most common cause of leg ulcers. Swelling of the lower extremities. So you see swelling. So it's relieved by elevation. Okay, relieved by elevation. Hurts more when you hang your legs over, right? Relieved by elevation. What about an arterial wound? Do you think it's relieved by elevation?
No.
You have to say no, right? Because it's relieved when the person hangs their legs down rather than when their legs are elevated. For a venous ulcer, the swelling is relieved. I'm sorry, the pain is relieved with elevation, and these people you can wrap. Okay, you can do a compression wrap. The other thing with these patients is think about putting this patient in a whirlpool for 30 minutes. Do you think it's a good thing?
No.
No, because the leg is in a dependent position. Dependent position means it's hanging down. So when the leg is in a dependent position, it can cause more edema or more swelling. So if you can do other things rather than put this person in a whirlpool for some kind of a debridement. I mean, I've seen it done, or I've seen them put in a larger whirlpool where they're actually sitting in the whirlpool rather than hanging their leg down. So this person will have an increased skin temperature, hemosiderin staining. Anybody know what that is or what it looks like? Okay, the blood can't be returned secondary to vascular incompetency, and therefore it pools. So it looks like a purple bluish color. So hemosiderin staining is like a purplish bluish color the skin has. The wounds are wet from draining exudate. Granulation is usually present. I'm not saying that these wounds aren't painful. They're not as painful as venous ulcers because venous ulcers are ischemic. This wound can be painful. You may see little pain, you may see some pain. Pain is relieved with elevation. You want to do compression located on the lower extremities proximal to the medial malleus. So if you see a picture on the state board of a wound over the medial malleolus, you'll know it's a venous ulcer. If it's on the lateral malleolus, you'll know it's an arterial ulcer. Okay, these are things you probably won't do, but you may see. Somebody puts a blood pressure cuff on that patient, you know, and they may also do this with a Doppler. And that pressure, it can't tolerate something over 40 millimeters. The patient has pain. Or Homenstein. Homenstein is pain in the leg when the foot is passively flexed. Okay, so a therapist sometimes does this. It's not 100% positive, but it is a test they use where they passively flex. When someone has a pain, Homenstein is actually done for DVTs, I'm sorry. So if we're talking about venous ulcers and we're talking about possible DVTs, we could do a Homenstein. Did we mention that last year? I don't remember. But a Homenstein is when the leg is out straight, the person is supine, and the therapist passively flex the foot, puts the foot into dorsiflexion, and to see if the person will have pain in the calf. So with venous ulcers, you know, or with any kind of ulcers, really, you want to make sure that the blood flow is adequate, and especially with a venous ulcer, you want to make sure they don't have a DVT. Okay. Arterial versus venous, and here it is. Location, oh, sorry. Location arterial, lower third of the legs, toes, dorsum of the foot, lateral malleolus. Location venous ulcers, proximal to medial malleolus. What does it look like? Smooth edges, well-defined, not much granulation or lack of granulation deep, little or no drainage. Appearance is irregular, shallow, a lot of drainage. Pain, severe, pain, mild to moderate. Pedal pulses, diminished or absent, it's arterial. Venous, normal. Edema, normal. Venous, increase. I'm so sorry. Hold on 1 second, please. I'm so sorry, guys. I've got, I don't know if my husband's in the hospital, so sorry about that. Edema, normal for arterial and increase for venous. Skin temperature, it's decreased for arterial, normal for venous. Tissue changes, isotropic changes. The skin would be thin, shiny, hair loss, yellow nails, brittle nails, dry skin, and venous ulcers, flaky, brownish, hemocinnamon staining, purple, blue. Miscellaneous, the leg elevation increases pain. So this person feels better with their legs hanging. Leg elevation lessens pain. So this person feels better with their legs elevated and wrapped. Okay, so compression wraps. No compression wraps for arterial. Venous versus arterial. What does this look like to you? It looks dark and discolored, right? It looks dusky, dark, discolored, not a lot of drainage, right? Yes? And arterial ulcers, lateral and more on the dorsal side of the foot. Okay. Neuropathic ulcer, neuropathy, we know what neuropathy is, right? Disease of a nerve. So the most common ulcer associated with diabetes mellitus is a neuropathic ulcer. And it's usually on the bottom of the foot, could be on toes also. And you'll usually see a callus. Okay, a callus around the neuropathic ulcer. Usually there's a percentage, don't quote me on the percentage, that used to be about 15 to 20 patients of diabetics will develop some kind of an ulcer in their lifetime, and those people that do develop ulcers will require some kind of an amputation. So there's an ulcer on the foot, weight-bearing surfaces, mid-foot, ball of foot, top of foot. You may see it with a Charcot deformity, and the Charcot deformity is when you have the bones become weak and they collapse. I'll show you a picture of it in a minute. And it's secondary to neuropathy, peripheral neuropathy. the patient has foot insensitivity. So we're going to, at the end of this talk, I'll show you that we have, there's monofilaments that a therapist will use to check for protective isolation. So we want to know what the patient can feel. And you want to know what the patient's skin temperature is. You want to know what the glucose levels are. Okay, so here's that Charcot deformity, and you get a subluxation of all these bones. And this is due secondary to some kind of a neuropathy. The foot will start to collapse, and they have what they call a rocker bottom appearance with the Charcot deformity. Okay.
But that's associated with diabetes?
Yes, yes. And these ulcers are usually occurring over some kind of a bony prominence, these neuropathic ulcers. Okay. We talked about show parts deformity the other day. I just put another picture in. This is the guy's unilateral show part, and then he's got some toes off of this leg. So he's got some buildups in his shoes and some modifications to his orthotics. So here's diabetic ulcer. What do we have to do with any ulcer? We have to measure it. You could see that this is a paper ruler that they use to measure it. You have to assess the depth, the length, the width, and they'll use this to assess the width and the length. You can see that this diabetic ulcer is a weight-bearing ulcer on the bottom of the foot, and you can see the callus formation here. Okay, and that's how they measure. All right, pressure, sear forces, maceration, infection, mobility. We said these affect wounds, the health of the patient, pre-morbid conditions, their skin condition, their body type, nutrition, are they hydrated, the distance between those wound edges, where it is, and if they have adequate blood flow. So we have to know the stage of the wound, okay? Remember I said, if the stage of the wound was initially a 3, you can't say it's now a 1. It's a 3 stage that's healing. You have to assess what color it is. Is it warm? Is it odoriferous? Does it smell? If it smells, it's indicating that there is there's possible infection. Exudate. Remember we said serous. Serous was clear. Sanguinous is what? Red, bloody. Serosanguinous is pink. Seropurulent is pussy and clear. And purulent is yellow. It's pussy. You're going to measure the size and the depth of the wound. You're going to measure it in centimeters using some kind of a disposable plastic or paper overlay. So you place this on top of the wound, so it's directed toward the patient's face, and there are numbers on this. I usually have one to show you in class. I will on one day. There's numbers like 12, 6, just like a clock, 12, 3, 6, 9. And you could say how large the wound is and what's the length and what's the width. And again, the depth of it is measured by inserting a sterile cotton tip swab, like the long Q-tip, vertically into the wound. So you're going to measure the depth of the wound, but then you're going to have to take that swab and move it horizontally in all sides of the wound to see if there's any tunneling. And if there's tunneling, then you take the wound, the stick out, and you see how far the tunnel went, you know, because you'll see the pink or the redness or the bloodiness or the yellowness or whatever it is on the sterile cotton stick. And then you could measure that and say how many millimeters you have of tunneling. Okay, that's indicative of a really, really deep wound. So here she's putting her finger in the wound. Okay, here the measurement is done. This is what I have in class, in school. I'll show it to you. It's a plastic overlay. And this is just a paper ruler. And finally, circumferential measurements, which are not as good on irregular surfaces as volumetric measurements. But I'll talk about that in 1 second. Okay. So you're going to describe the wound. And we're describing the wound to say, what's it look like? Does it tunnel? How big is it? Does it smell? Is there exudate? And if there is, how much? Is it thick? Is it thin? Is it watery? Red will indicate that the tissue is being granulated, so it's healing. Yellow, tan, or a grayish brown indicates slough. And Eschar is black. So you want to note the surrounding skin around the wound. So here, what do you see? What are these? Anybody?
Pressure ulcers,
What, where?
the ischial tuberosity,
Right, ischial tuberosity. Now what's this?
sacral,
Yeah, sacral ulcers. And then we have one on the ilium over here. I mean, there's one starting here. So there's a lot of ulcers. They're measuring the ulcer. What's this yellow stuff? Slough, right? Slough. Yellow, grayish, brownish slough. It's got to all be removed. All right. So what do we have to do? We have to debride the necrotic tissue. We have to clean the wound. We have to dress the wound. And there's other things that you could do for wound care. Hypobaric chambers and different things like that. Debridement, sharp debridement. You probably won't be doing it. It's not in your plans of care, which is a good thing, I guess. But we used to do sharp debridement, and who knows, it may change. Usually the physicians and the nurses do sharp debridement with scissors or scalpels to debride the tissues. Mechanical debridement is known as non-selective. Okay, so sharp debridement is selective debridement, mechanical debridement is non-selective. So they could do something like a pulsed lavage where they spray, it's almost like a shower head, where they spray something into the wound and all the debris is pulled out through another hose. So as it's spraying, it's actually pulling out the debris. You could also do non-selective debridement by removing a dressing. So as you remove a dressing, you're removing everything that's under the dressing. Hydrotherapy by placing them in some kind of a leg tank or arm tank, or if it's a huge amount of area, they could place them in a hover tank. And also through electrical stimulation. So we could use E-stim, we could use high volt. We'll talk about it in a couple weeks, that there's negative and positive polarities. And if we want to get rid of edema, we would use a negative polarity. And we can treat a wound with both a negative and a positive polarity. Selective debridement can be enzymatic or can be autolytic. And remember, an autolytic debridement, the example of that is we can apply a moisture retaining dressing, and we could change it once a day and put it on the patient. When the moisture will accumulate, the old tissue underneath will swell up and separate from the wound, and that's more of an autolytic debridement. Enzymatic debridement is something where, you know, pharmacy comes into play, and you can apply collagenase to the wound to debride the wound. So that's exogenous versus endogenous. Endogenous means that it's debrided, our body debrides it, and exogenous means that we need some kind of an enzyme or something to help with the debridement. Okay. Nutritional support. Again, you can't emphasize how important it is to have nutrition. Increase subcutaneous tissue to improve patients' metabolism. And as I said before, that parenteral feedings or some kind of feedings, you know, if they require IV feedings or they require a tube, a catheter to feed them, then so be it, they need it. If not, they can take things like Ensure, and there's other products on the market that they can take. All right. Non-selective, another non-selective debridement, wet to dry. They don't use this so much anymore, wet to dry dressing, because the dressing is wet, and then when it dries, they pull it off. But what happens? What do you think happens?
And rip off any scabs or anything that's under it.
Well, it removes the necrotic as well as the living tissue. So they use a wet to dry dressing, right? So they're really not considered, they don't do this so much anymore, but yet your book talks about it. It removes the necrotic tissue, but it also removes the living tissue. So a pulsatile lavage is that has a suction device with it, and as I said, it pulls out the contaminants as it starts to flush out the wound. Then there's hydrotherapy, which is a whirlpool. The whirlpool can loosen the necrotic tissue so that you could easily get it off, or it could just loosen the necrotic tissue and then maybe it needs to be debrided. Hyperbaric oxygen is 100% oxygen that may help with wound healing. And this negative pressure wound therapy is, there's this suction tube. They put this foam in the wound with a suction tube. They cover the wound. They put a clear occlusive film or dressing over the wound, and it suctions out the wound as it starts to heal it. So that may be something that you may see, this negative pressure or wound vac. Sometimes they use the word wound vac. You may see these in some subacute facilities, and these are the pulsatile lavage. And here is an example of a hyperbaric oxygen. Okay, I haven't seen one of these, and they usually came portable. And when I was treating wounds a long time ago, even as a PTA, they had little hyperbaric wound chambers that they used, and they're coming back, so you may see them. Why do we do a dressing? We do a dressing to protect the wound, to assist in healing, to reduce infection, to remove the exudates and the waste when we remove the dressing. And you want to be careful how you take off that dressing to avoid trauma to the outside. And if the dressing is stuck to the wound, you may want to flush it with saline before you take off the dressing. Okay, and you want to document any kind of observed changes. All right. Now this you don't really have to know so much about, because these things change and they're named differently in different facilities, and different facilities use different types of dressings. But there's something known as a transparent dressing, and some examples of it, what you may see in a clinic is something called Opsite, O-P-S-I-T-E, or Tegaderm. They can be used for autolytic debridement. They don't allow the bacteria or moisture to get into the wound. Okay, it's self-adherent. It's not for use when with a wound that's draining or infected. Okay, and they're just for stage 1 and 2 wounds. Hydrocolloid, and these first 3 are really autolytic. The hydrocolloid is, what does hydro sound like to you? Water, right? Hydrocolloid. This is for stage 2 and 3 wounds with minimal drainage. It will make sure that the wound stays wet. So hydrocolloid water, bringing fluid or keeping the wound wet. You don't do it for an infected wound, and it's best for mild to moderate draining wounds. Hydrogel is for necrotic wounds. There's sometimes liquid sheets that they put on that they contain 90% of water, and the water moisture you put into a dry bed of a wound, and it'll soften the necrotic tissue. So that's a hydrogel. You put this moist bed on a wound and you cover it with cling. Cling is just a bandage. That's all it is. Wet to wet is safe for a wound that's on stage. It needs changing to maintain that you have a wet base. So it's a wet wound. It's a wet 4x4, and then you place the sterile bandage on top of it. You wet that. You keep the wound wet. Wet to dry, as I said before, it's for debridement, but it's because it does remove necrotic tissue. So if you're having a wound that has mostly necrotic tissue, you can use a wet to dry, because you're going to take the bandage off and you're going to have necrotic tissue come with it. And then finally, this one is something that the state board does ask about, because this is the one that's used for infected wounds, calcium alginate. All right, it's derived from seaweed, and then there's a chemical reaction between the dressing and the wound, and that will create a jelly-like substance that will help maintain a moist environment while it does absorb the excess exudates. Okay, so it creates a chemical reaction between the dressing and the wound. It maintains a moist environment. Cover with dressing. It's used with infected wounds. Okay, I'm wondering if this is still working. Let's see.
A stage 1 pressure ulcer presents as intact skin with non-blanchable redness of a localized area.
Yes, see,
Usually,
So we
Professor.
don't see it.
Darkly pigmented skin may not have visible blanching. Its color may differ from the surrounding area.
Yes.
The area may be
You see it?
painful, firm,
Wait, go back.
warmer, or cooler as compared to adjacent tissue.
Yeah, we don't see it.
How about now?
No.
Stage 2 pressure ulcer is characterized by partial thickness loss of the dermis, presenting as a shallow open ulcer with a red-pink wound bed without slough. Others may present as an intact or open or ruptured serum-filled blister. This stage should not be used to describe skin tears, tape burns, perennial dermatitis, maceration, or
Wait a minute.
excoriation.
Wait a minute.
A stage 3 pressure ulcer involves full thickness tissue loss.
All right, you guys have to help me
may
here.
be visible, but
It's like
bone
We saw it for a second. I
are not.
don't know what happened.
Slough may be present, but does not obscure the depth of tissue loss.
Now I can't.
Stage 3 pressure ulcers may include undermining
Oh, my
and tunneling.
Screen is paused.
A stage 4 pressure ulcer involves full thickness tissue loss with exposed bone, tendon, or muscle. Slough or eschar may be
My
present
screen
on
is
some parts of the
paused.
wound
Hold
bed.
on, guys.
A stage 4 pressure ulcer often involves undermining and tunneling. Deep tissue injury
see
is
that,
defined
right?
as a purple or maroon
You'll see the PowerPoint.
area
You
of
do.
discolored intact skin
All right.
That's
or
the PowerPoint.
blister due to damage of underlying soft tissue from pressure and or shear. The
Darn.
area may be preceded by tissue that is painful, firm, mushy, boggy, warmer, or cooler as compared to adjacent tissue. A pressure ulcer should be described as unstageable if the
Okay, there you go.
All right.
appears by eschar or slough. Until enough
No. Oh, wait. Yeah, hit that.
slough and or eschar is removed to expose the base of the wound, neither the true depth nor the.
Okay, sorry.
A stage 1 pressure ulcer presents as intact skin with non-blanchable redness of a localized area, usually over a bony prominence. Darkly pigmented skin may not have visible blanching. Its color may differ from the surrounding area. The area may be painful, firm, soft, warmer, or cooler as compared to adjacent tissue. A stage 2 pressure ulcer is characterized by partial thickness loss of the dermis, presenting as a shallow open ulcer with a red-pink wound bed without slough. Others may present as an intact or open or ruptured serum-filled blister. This stage should not be used to describe skin tears, tape burns, perennial dermatitis, maceration, or excoriation. A stage 3 pressure ulcer involves full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. Slough may be present, but does not obscure the depth of tissue loss. Stage 3 pressure ulcers may include undermining and tunneling. A stage 4 pressure ulcer involves full thickness tissue loss with exposed bone, tendon, or muscle. Slough or eschar may be present on some parts of the wound bed. A stage 4 pressure ulcer often involves undermining and tunneling. Deep tissue injury is defined as a purple or maroon localized area of discolored intact skin or blood-filled blister due to damage of underlying soft tissue from pressure and or shear. The area may be preceded by tissue that is painful, firm, mushy, foggy, warmer, or cooler as compared to adjacent tissue. A pressure ulcer should be described as unstageable if the base is obscured by eschar or slough. Until enough slough and or eschar is removed to expose the base of the wound, neither the true depth nor the stage can be determined. To learn more about moist wound healing and other key concepts in wound care, you may wish to consider becoming certified as a wound care specialist. The benefits of wound certification are immeasurable, both to your own career and to the standard of care that you can offer your patients. And because Medicare and other organizations are now holding healthcare professionals responsible for outcomes in wound care, there has never been a better time to become a wound care specialist. WoundEducators.com is dedicated to helping you take this all-important step in your career and to help you handle any type of wounds you may encounter in your daily practice.
Okay. So you guys good?
Yep.
Yes.
Okay. So, where are we? These are types of things that we could use in facilities to prevent wounds or pressure, actually pressure sores, to develop, and they're sheepskin wraps. So this is sheepskin with a Velcro. And sometimes you see these in elbows, you see them on feet, see them on patients that are dependent for a very long time. Because if you could, as I said earlier, the best thing to get these patients to do is move. So if they're not able to move and they're comatose or something, you have to accommodate their limbs somehow to prevent them from getting breakdown. And remember, what would you think you'd see at the top of the bed? Turn patient when? How often?
But is it every 2 hours?
Every 2 hours. Absolutely, every 2 hours. Okay. So when there's circumferential measurements, and they evaluate edema and atrophy, and we did a little of this in class. Remember, I don't think we measured. We did measure, didn't we? Measure for edema or for atrophy? No.
No.
Well, if not, we will, because we're going to be using the Jobst compression pumps, and we will have to assess lymphedema. But anytime that we're working with somebody who has a problem, we need to measure or some kind of a lymphedema, I should say. We're going to have to measure them prior to and after our intervention to see if our intervention worked. So circumferential measurements, generally what you do is you find a bony prominence. So if I was going to do the lower extremity and I was going to measure from the lower leg, I would put a mark above, and I always like to do above because you could hook your fingers onto something. So I always go above the malleoli, and then you can go 2 centimeters, 4 centimeters, 6 centimeters. So if you go 2 centimeters, you make another little mark. 4 centimeters, you make another little mark with a pen, and 6 centimeters, make another little mark, and do a circumferential measurement. This way, you know. Otherwise, if you just measure somebody and say, well, I'm going to measure the mid calf, how do you know next time or after your intervention that you're measuring the same spot? You don't, unless you have some kind of a mark there or some kind of a tool to use that, I mean, you're still going to have some error, but the error is not going to be as great as if you didn't have some kind of marking there to begin with, okay? So measure the circumference to evaluate for edema and atrophy. Indications would be for edema, for lymphedema, for atrophy. You're going to identify that bony landmark. So is it a malleoli or is it a patella, tibial tuberosity, whatever it is. You can determine the next site, you're going to mark it, and you're going to go up. You're going to use a measuring tape, wrap horizontally around the area. measure at least twice. Sometimes you measure 3 times, you take the average, just so that you don't, you decrease error. However, if you're working with a patient that has irregular surfaces, such as a foot or a hand, you may need to use something known as a volumetric measurement. Okay, what you do is you have this plastic cylinder, and you have a measuring cylinder here on the side. So this calibrated spout and cylinder, this plastic thing. And I don't know if you could see it right in here. Can you see that? There's a little plastic bar. And generally what you do is you place your hand in the cylinder or your foot in the cylinder, and it doesn't touch the bottom, but it stops at this plastic bar. And you place, well, first of all, you have to fill it. Let me go back. You have to fill it with water until it stops leaking. All right, then you empty out this. Once it stops leaking, you ask the person to insert their hand. So if they have swelling in the right and no swelling in the left, we would do the left hand first, and we do a recording. So this calibrated cylinder here catches all the overflow of water that has been displaced by the hand, right? And you look at the measurement. Then you would place their right hand. Remember, we said it was the left hand we were doing first. Now they'll place the right hand. We'll have to fill it up again, do the same thing again, have them put their hand in, and then have them insert their hand slowly into the water and wait until all this water comes out of this spouted cylinder, and it'll give us a reading. Now, what do you think, if this is based on milliliters, and let's say the right hand has measured, the left hand that was not edematous, didn't have any edema, measured 320 millimeters, and the right hand measured, what did I say? Left hand is 320, and right hand is 360. What does that indicate to you?
There's that the right hand is more edema.
Right, right. So the higher number, if one is 320 and the other is 360, the higher number indicates that there's edema, more edema, right? And it gives you it's because it's you're displacing fluid. Well, I'm sorry, my head is not here today. The fluid displacement caused by the edema. Okay, so the greater the number, the more swelling there is, the greater displacement. Okay, so if the right is, if you have a larger number when comparing both sides, the larger number is the one that has edema. Okay, and this is, yes.
For people, if you're doing like say bilateral, if they have diabetes, is this a test that you would use for it, or?
Well, if I'm, no, probably not. You're probably not going to do something like that. You'll probably use this more for somebody who has lymphedema.
Okay.
Okay. But you kind of want, or let's say not even lymphedema. Let's say somebody's got bilateral, what's the word? Come on, guys, you got to help me with this. Not a Smith's fracture, Colles fracture. Colles fracture. What if somebody's got a bilateral Colles fracture, and they have resultant? What's a Colles fracture? Anybody?
Fracture of the distal radius?
Fracture of the distal radius, right? Fracture of the distal radius resulting in a fork tine deformity, right? Where you get the dorsal aspect of the bone is elevated in the lower fourth of the forearm. So if somebody's got bilateral edema, we could still do this with them. And let's say they have weakness, or they have a decreased range of motion. Is edema going to give you a decreased range of motion? Yes.
Yes.
Yes. edema will give you a decreased range of motion. So if you see a decreased range of motion and you want to know why, or you want some kind of a objective measurement, you have to be able to say, well, because it's edematous. And not even just looking at it, but you have an objective documentation of what the edema is. So you may be able to do both arms and see which one is worse. And, you know, a lot of times that goes along with what a patient is saying, because the patient will say to you, you know, I'm right-handed. And the other thing I want to tell you is that there may be a little difference in your right or left hand. Those of you who are right-handed may have a greater volume, you know, greater amount of muscle bulk, et cetera. So that number may be a little bit higher. And those of you on the left, same thing. But this just gives you a reading, and it's more accurate than trying to take a tape measure and measure your wrist and measure your forearm and measure your fingers. So this just gives you a better reading. Okay, volumetric measurement. And then finally, these monofilaments are used for sensory assessment. There's all different types of filaments. You'll use them next year in neuro. And what you'll do is you'll place, you could see that this is a plastic stick with what is attached to it is a filament. And what she's doing is she's placing it on the area of skin and just taking it to a slight bend until the filament bends, and assessing if the patient can feel it. So I don't know the numbers associated with these filaments. They're usually done with occupational therapists, but there's a chart and it tells you, you know, this is normal, that's decreased sensation, minimal decreased sensation, mild, moderate decreased sensation, severe decreased sensation. So they'll take this and they'll place it in specific areas of the hand and the feet to see if you can feel the filament. Okay, so that's another way they test for sensation with diabetics. All right, the next thing is catheters, and I really don't want to go into that because there's so much that you have to do in lab. Is Anita there?
Yeah.
Anita's there? Okay. Can Anita hear me? Yeah. Okay. Anita, can you bring them over to lab early and get Professor Maley too? He will come into lab. He has the gloves and he can go up and get another, I'll call him, a sterile field and gowns. So they'll be donning and doffing gowns today and gloves. And if time permits, to attempt 4-inch and 6-inch stump wrapping.
Sure.
Okay, so that's what I want them to do today.
So Professor Malley is going to get the sterile field stuff.
Yes, yes. So you can go over it early and then hopefully start the other class early too.
Yeah, no problem. Do you want us to head down now?
Yeah, well, give them 5 minutes, 10 minutes, whatever, and then head down.
Okay.
Okay? All right, thank you.
You're welcome.
And ladies and gentlemen, are they all there yet, Anita, or not?
Yeah, I believe everybody's here.
Okay, I've got a question, or I could ask it to Ashka. Ashka, are you there?
Yeah.
All right. Would you guys, and please, you can get back to me with this. Is it at all possible, instead of Friday between 9 and 12, to meet on Thursday night for Zoom, just a short one, like 5 to 7 or 5, you know, something like that, not a 3-hour 9 to 12 on Friday. Can you just survey the class and find out if that's possible? And
Yeah, I'll everybody's here, but I'll send you an email later on today just to let you know what everybody says.
Okay, all right, thank you very much.
All right, yeah.
All right, bye-bye.